and welcome. My name is Feroz Mahmood. I'm the Chief Division of Cardiac Anesthesia at Beth Israel Deaconess Medical Center in Boston and professor at Harvard Medical School. These are my disclosures. I'm a consultant for Abbott Medical Systems as well as GE Ultrasound. So the outline of the talk is that we will go over the history of mitral valve repair and annuloplasty, principles of annuloplasty, types of rings, the impact on mitral valve apparatus, and finally go over the ring sizing. So first of all, why it is important for us to know the types of annuloplasty rings. Mitral valve repair is a frequently performed operation. The pre-cardiopulmonary bypass intraoperative TE interrogation of mitral valve is critical to repair planning. A repair is termed successful only if the post-cardiopulmonary bypass TE examination is satisfactory. There's a signature appearance of the annuloplasty rings both structurally and functionally. They have characteristics of their flow patterns. It's questionable whether we can predict their durability. However, at the end of the day, transesophageal echo provides a roadmap for mitral valve repair for which annuloplasty ring identification, both structural and functional, is critically important. Now, going over the history of mitral valve repair and annuloplasty. So this is one of the first papers regarding cinching of the mitral valve, that is, narrowing of the mitral valve orifice by cinching was initially performed to create animal models of mitral stenosis to do research on mitral stenosis, that is, rheumatic mitral stenosis that was kind of an epidemic in the early 20th century. In a similar situation in 1954 by Dr. Borey, a patient was operated for mitral stenosis for finger commissurotomy and was found to have annular dilation and mitral regurgitation only. And that's when it struck to them that it could be possible, like they said in this paper, to cinch the mitral valve, that is, to reduce the annular area so that the leaflets can have reduction in the tension and can have better coaptation. And as they pointed out over here, they said, the best means of accomplishing our purpose appears to be the placement of a constricting ligature or purse string around the atrioventricular ring, that is the mitral valve annulus, and that's the idea of mitral valve annuloplasty first proposed in 1954. Now, if you look at the original description, this is analogous to having a sheath in a drum, and when the drum side is cut into two pieces, that is, the two leaflets of the mitral valve, they come under a certain degree of tension, and therefore now the size of the mitral annulus has to reduce to match the reduction in the surface area of the leaflet so that they can coapt optimally in the center of the leaflet. So therefore, after mitral valve repair, annuloplasty accounts for reducing the annular area so that to account for the reduced surface area of the mitral leaflets that have been resected as a result of repair. So that's the principle of annuloplasty. Now, going over the replacement to repair surgery, that mitral valve replacement was thought to be the default mitral valve surgery because there was no support by the cardiopulmonary bypass. It's only when the cardiopulmonary bypass was available that the surgeons had the ease of doing an actual and a detailed and a thorough comprehensive mitral valve examination when on bypass, and when they began to realize that not all leaflets are as diseased that they deserve replacement, and some of them could possibly be repaired as well. So that's the heralding the start of the cardiopulmonary bypass gave the surgeons the time and the convenience to examine the mitral valve on cardiopulmonary bypass to design for repair. This is this famous presidential address of Dr. Alain Carpentier, the picture of whom you saw in the last slide, where he suggested mitral valve repair as the French correction as an intelligent reference to the famous movies of the 70s, French Connection, starring Gene Hackman, again related to some crime being committed by a French connection in that movie. So in this specific article, he has referred to the concept of mitral valve repair as repair of a mitral valve apparatus that consists of trigones, the aortomitral curtain, the anterior mitral leaflet, as well as the fibrous mitral annulus. And doing this thing, they have pointed out that the principles of reconstructive surgery of degenerative mitral valve disease include, and the goals are, preservation and restoration of normal leaflet motion, creation of a large surface area of coaptation between the anterior and the posterior rings, and finally, the application of a stabilizing annuloplasty ring in that patient. Therefore, the principles of annuloplasty based on Dr. Carpentier's classification are preservation, and that is restoration of normal motion. Please keep that in mind. That's one of the most important ones. Secondly, the even more important one is creating a large area of coaptation between the anterior and the posterior leaflet. And finally, annulus stabilization with an annuloplasty ring, that is to account for the resection and reduction in the leaflet surface area by reducing the projected area of the mitral annulus. Now, the function of the mitral valve are to have diastolic non-restriction, that it opens completely, and diastole and systolic competence, which means both leaflets coapt adequately to prevent any regurgitation coming out of the mitral leaflets. Now, in this context, one of the most important concepts is the 4:3 ratio. This is also referred to as the golden ratio of architecture of human anatomy, which was somewhat, I wouldn't say discovered, but promoted by Leonardo da Vinci, the famous, Middle Ages artist, scientist, as well as an engineer, that everything architecturally conforms to 3:4 ratio. That's referred to as the golden ratio. And mitral valve, both the AP and the anterolateral posteromedial diameters also conform to the same ratio of 3:4 to 4:3. However, in chronic mitral regurgitation, what happens is that the leaflets, increase in the mitral annular diameter increases in the AP dimension more than it increases in the anterolateral posteromedial dimensions. For example, if you look at it, this is a valve on the right side, is a leaflet, is a valve which is dilated in the AP diameter in the 4:3 dimension, leading to significant mitral regurgitation. So this is a distortion of the mitral annulus in which leads to significant mitral regurgitation. So this is the AP diameter. This is the ALPM diameter. On the contrast, the AP diameter increases more than the ALPM diameter in the chronic patients with chronic mitral regurgitation. Now, this is important because the valve goes through a sphincteric action. That is, in diastole, the AP diameter increases, and cyclically, the anteroposterior diameter tends to decrease in systole, so that it has a sphincteric action which is more in the AP dimension. Therefore, the valve expands more in the anteroposterior dimension, and that's why it's important to preserve and to restore the AP diameter when the valve is dilating or the annulus is dilating and the patient has significant mitral regurgitation. So therefore, it further clarifies the principles of annuloplasty in this sense that we need to have equal apposition of posterior and anterior leaflets. We tend to reduce the height of the posterior leaflet after repair. Then we stabilize the anterior leaflet by doing and remodeling annuloplasties. The way as you look at it is simply to account for the reduction in the leaflet surface area. So at the end, structurally, we do annuloplasty to restore the shape of the mitral annulus. We do annuloplasty to restore the diameter of the mitral annulus. We do annuloplasty to maximize coaptation, and finally, to prevent further dilation of the annulus. In this context, there are multiple rings. Now, this is not as simple as it sounds, whereas the principles are pretty straightforward, the approach is pretty complicated. So, the aims are prevention of regurgitation and prevention of annular dilation. Now, what the surgeons do when they're performing an annuloplasty is fixing the mitral annulus in an end systolic phase, because that's when the most action happens. That's when you need the most coaptation. That's when you need the reduction in the AP diameter, that the annulus is fixed in an end systolic position on bypass. So therefore, every dimension we make has to be made in the end systolic position. Now, the rationale for ring selection is that we fix the annulus in end systolic position. We ignore that sphincteric action that I just mentioned to you, because we want the annulus and the leaflets in the end systolic position, demonstrating the maximal coaptation. And despite knowing that annulus is a very dynamic sphincteric structure, we just ignored it. And the limitation was more or less technological, not intellectual, because we knew the annulus is dynamic, but there was no better way of restoring or maintaining annular dynamism while performing an annuloplasty. This is not until, in 2010, 2012, when we did this study on, dynamic analysis of the mitral valve in the operating room to demonstrate for the first time that in vivo, the annulus goes through a lot of conformational changes in three-dimensional space that include, excuse me, contraction, changes in its saddle shape, as well as its, translation motion over time. And if you look at the studies, that includes many that we performed ourselves, there are all sorts of descriptions of the way the mitral annulus changes conformationally during systole and diastole. And a lot of it are contradictory. And now, I'm not stating that one is better than the other or one is, more correct than the others, but the differences or the contradictions can be explained on different methodologies, two-dimensional or three-dimensional, echocardiography, fluoroscopy, and technical definitions of end systole and diastole. And therefore, you tend to, ignore certain points, and some with higher frame rate, higher heart rate. When you have more frames to analyze, you can analyze more dynamism and different changes than the ones you have less, frames in them. So therefore, it is kind of out there how the mitral annulus changes and when it assumes its maximal diameters, either in systole or in diastole. Well, to address this specific issue in 2014, we did this study of looking at the mitral annulus throughout the cardiac cycle with a very high frame rate. I'm not going to go into the detail of how this was achieved, but for those of you who are interested, can read this paper. But in this specific study, what we demonstrated was that rather than having specific times of, maximal diameters and anteroposterior, anterolateral, the annular area changes through phases, which means an expansion phase that starts middle of systole when the annulus starts to get ready to receive a lot of blood from the left atrium and direct it into the mitral, into the left ventricle. And then there's a contraction phase which starts late in diastole and transcends the clinical systole and diastole and goes into, systole, which means it doesn't really matter when you get which specific point in cardiac cycle the annulus has its maximal diameter, because it's variable. So you should tend to get the maximal diameter whichever phase you get it in, because the annulus is the dynamism is in phases as opposed to discrete points in the way we define systole and diastole clinically. And we took this upon ourselves to demonstrate the clinical value of this information and also demonstrated clinically that there are significant changes in patients who had functional mitral regurgitation and dilated annuli. As you can see in this specific study with patients with functional mitral regurgitation, we demonstrated that not only that they had a larger area at baseline, that's both the functional mitral regurgitation as opposed to controls, but also they had less dynamism, or delta change in mitral annular area was far less in patients who had functional mitral regurgitation, implying that these patients had the sphincteric action was lost in them, and they did not behave as efficient as a sphincter as in normal patients. And that kind of is intuitive, because these patients also had significant mitral regurgitation with the loss of sphincteric action of the annulus. And in this, in a follow-up study, we demonstrated that both the anterior part of the annulus as well as the posterior part of the annulus are dynamic. And if there's one area that doesn't change as much as the others, that is the intertrigonal distance. That is, it's a very, welcome finding, because that's commonly used as something to assess the annular area, the sizing of the mitral annulus. And with the advent of three-dimensional echocardiography, we were able to demonstrate that in real time. This is one of our first 3D images of the mitral valve that we got in 2004. And you can see that the annulus changing its size both anterolaterally, posteriorly, as well as anteroposteriorly. However, the intertrigonal distance that extends from here to here stays pretty constant in these patients. So that was a very good finding in these patients. So now we come down to knowingly the changes in the annulus are not predictable. They happen both anteriorly and posteriorly. We come to what are the different kinds of rings. So the first kind of ring were complete rings. That is, they were encircled the annulus completely to provide a support around the annulus. The Carpentier classic ring was completely rigid and was sized to the anterior leaflet, which means the AP diameter of this annulus, of this device, was to the length of the anterior leaflet. So the counter one was the Duran annulus, which was completely flexible. And as you can see, the diametric nature of the approach, one assumed that it is extremely important to fix the mitral annulus in a rigid, flat position. And the other, school of thought was we have to have a ring that is completely flexible and less distortion. So early in the literature, there was a lot of debate of which one is better, rigid or the flexible. Like you can see in the slide, the rigid rings resulted in a more reliable reduction in mitral regurgitation, more reliable prevention of further dilation. However, there was significant impact on left ventricular function. Flexible annuloplasty rings were associated with preserved dynamism of the annulus, improved function. However, there was less reliable prevention of regurgitation or ulnar dilation. And over time, people have come to believe that somewhat rigid rings are better than the flexible rings, and completely flexible annuloplasty rings are not used that often in there. Now came the second generation of rings, where we go down to the Carpentier or the Physio 2 ring, which was based on the principle that we need to, the most flexible part of the annulus is the posterior annulus. So we need to fix the posterior annulus maintain the flexibility of the posterior annulus and fix the annulus anteriorly. So the classic Carpentier Physio 2 ring is rigid anteriorly and flexible posteriorly. And they assume, and the claim is, that the posterior flexibility allows more physiological motion. It is a little saddle shape as well, and therefore it allows the annulus to change anteroposterior diameter. Quite predictably and diametrically opposite to it is the CG Future or the Colvin-Galloway ring, which was put forward by the Medtronics people. It is rigid posteriorly because they believe posterior annulus is the one that dilates the most. So therefore, we need to fix the posterior annulus, and the anterior annulus is kept flexible. Now, their claim is that it allows the annulus to maintain 3:4 golden ratio, and also allows the ring to maintain a sort of sphincteric action, that the posterior annulus remains fixed, and the flexibility of the anterior portion allows for the change in the AP diameter, as you can see on the graphic on the right side. You can see they still do not seem to agree that which of the annulus is better than the other one. So going further on this one, we actually did a study where we randomized patients into either getting Physio 2 rings or the CG Future rings to demonstrate whether these manufacturer claims of in vitro flexibility can be demonstrated in vivo as well. And lo and behold, quite to our surprise, that we found that within the physiological force range, both of these rings are uniformly rigid, and the selective flexibility that is demonstrated in vitro cannot be seen in vivo, which means that was purely a manufacturer claim for which we were paying a lot of premium price for it. And just because we could bend it in our fingers outside the heart doesn't mean that the heart was able to do it in the body. So the study received a lot of criticism, but it did demonstrate that there's a lot of commercial hype in many of these rings, and all of them, the complete rings, whether they claim to be selective flexible anteriorly, posteriorly, are all not flexible in vivo. Now came the next concept, where they suggested that in all the rings we assume that the anterior part of the annulus is more rigid, less flexible, and not as mobile as the other one. Why don't we just completely ignore the ring, and as you can see on this video, have a band that extends from one trigone to the other and support the annulus where most dilation occurs? So there's a band which is anchored from the medial to the lateral trigone, and therefore prevents the dilation of the posterior annulus. Now, this is kind of best of both the worlds. And now there's a plethora of rings which are from St. Jude, CG Future, Cosgrove Edwards, Medtronics, you name it, and they have bands of different kinds which they claim are flexible. They have more saddle shape, preserve more geometry, but they're all based on the same principle, that the anterior part of the annulus remains rigid and the posterior part remains more flexible, and we should pay more attention to that part. In this context, we also published this study in 2008, where we demonstrated that there's geometric assumptions of mitral annulus that are claimed by these manufacturers can actually be tested in the operating room. And we demonstrated that complete rings and bands result in reduction in mitral annular area, which is equal, which means Even if it's a band or a ring, it results in an equal reduction in the area. However, the complete rings quite reliably make the annulus very flat, which it is a saddle shape, and the bands tend to maintain the annular geometry, which means they cause less geometric distortion. However, now we're coming down to can we differentiate these rings or bands on the impact on mitral annular geometry? And is it all about annular area reduction so that the leaflets can coap with each other very well? Now, you all know that in 2002, a paper in Circulation demonstrated that this saddle shape of the mitral annulus is preserved across species, and it is associated with a certain degree of mechanical advantage because at height of systole, the annulus assumes more conformationally saddle position that reduces leaflet stress. And just as a point of interest, that this was also the Pringle chip company patented this saddle shape, and the chips can be now were stacked on top of each other to reduce stress and prevent any breakage. So that's a patented shape by Alexander Liepa. However, coming back to the topic, the assessment of the saddle shape was also considered a very research topic, that they measured the annular height commissural width ratio, which is a pretty complicated thing, which I'm not going to go into the detail. And this was seen as the more saddle-shaped the annulus, the higher the annulus. As you can see in this specific graphic, that the annular height is associated with smaller interpeak distance, which would lead to a more saddle-shaped annulus. And mathematically, it has shown that when the annular height commissural width ratio is less than 20%, the stress ratio tends to high. Now, we in our initial study described a very clinically relevant non-planarity angle, which is subtended across the ALPM diameter of the mitral valve, which can be used to assess the non-planarity or the saddle shape of the mitral annulus, which means the larger the annulus, the larger the non-planar angle, the flatter the annulus. And it is also associated with reduction in annular height commissural width ratio. And so, therefore, this is the non-planarity angle subtended at the anterolateral posterior medial diameter. So, which means the smaller the angle, the more saddle-shaped the annulus. And in this context, when this information was put forward, manufacturers started making these saddle-shaped rings, which was all of them were complete. They were rigid and also saddle-shaped. We also did a study in 2012, I think, where we had these saddle-shaped rings implanted into the patient to demonstrate that flat rings, whereas reduced non-planarity of the mitral annulus, the saddle rings significantly increase the non-planarity of the mitral annulus, which means they actually do what they were supposed to do. And the same effect of the multiple vendors on the saddle shape as we can be seen, So that was all about the structural impact of the rings on the mitral annulus. Now comes the functional impact of these rings, which means color flow Doppler, and we normally pass a mitral valve repair when there's no regurgitation and there's no stenosis. However, in this reconstruction of the inflow vortex from LA to LV, you can see that this is a pretty tilted, a vorticial flow from the LA to the LV, And really, it depends on how much posterior leaflet is preserved during annuloplasty, which means the more posterior leaflet is preserved, the more tilted and the more convoluted is the vorticial flow in there. And and the bands seem to have a more vorticial flow into the LV as opposed to the rings. Now, the clinical significance remains to be established, but this can impact your continuous wave Doppler and gradient adjustments into it. Now we come down to the last part of it, which is sizing of the annuloplasty, and where does science stop and voodoo begin. There's a great article in Annals of Thoracic Surgery from 2013 where they went over the different sizing strategies that people have used of mitral annuloplasty devices. And lo and behold, what they've demonstrated was even the same sizes, but same size, devices and sizes between manufacturers have different dimensions. So it is really more or less an art more than a science of sizing what kind of annuloplasty device to be used. We may try to put it forward as a science, but it is not. Most people have their own way of sizing rings, and most of the time it is sized either to the intertrigonal distance or the length of the anterior leaflet. Now, when it comes to echocardiographic identification of annuloplasty rings, it is not possible reliably with 2D or 3D echocardiographic examination. You can have partial, full, flat, or saddle, as you can see with 3D echocardiography. Functional assessment does not separate the annuloplasty devices. However, geometric distortions of annulus and leaflets can differentiate different annuloplasty devices, as I've gone over in the presentation in the last few slides. So whether or not we can determine durability of repair, that is still a science in progress and hasn't been established conclusively. So what we know so far, rigid full rings reliably prevent mitral annular dilation but impair ventricular function. Flexible full rings and partial bands preserve ventricular function but are not as reliable in preventing further annular dilation. Rigid and flexible rings make the mitral annulus flatter and less non-planar. Partial bands do not affect the mitral annular non-planar shape, and the annulus stays as non-planar as it is. Saddle-shaped full rings augment the saddle shape of the mitral annulus that we've described and established. Significant changes in mitral annular geometry with annuloplasty, that is a universal change, so there's significant conformational change in the mitral annulus. So present analysis are based on either crude flow-dependent variables, that is, an analysis of the rings is based on how much MR we have and how much stenosis we have, or a single-frame 3D analysis. So conventional geometric analysis performed on a static end systolic frame, which the limitation is that they are snapshots of a continuous process. They're not representative of the entire cardiac cycle. They extrapolate information from a single frame and put it on the entire cardiac cycle. That's a major limitation. And we do not have, as such, real-time dynamic geometric analysis of annuloplasty devices in vivo. And finally,